Namaskaram. Assalamu alaikum rahmatullah. Some of the people are from US. For them, good morning. And I would like to express my sincere thanks for accepting this invitation to attend this wonderful webinar scientific session conducted by Academy for Laboratory Science. Last 1 month, we have started many webinars. Every Sunday, we are conducting webinars on various topics related with medical laboratory science. Last two sessions were on career path. The excellent and prominent personalities from medical laboratory technology were doing their sessions. I express my sincere thanks to all my teachers. I can see some of my teachers from my college, Medical College Trivandrum, they are here to attend this wonderful seminar. And my colleagues from Zayed Military Hospital, and my friends, my students. I warmly welcome all of you to this wonderful session. Today we have a wonderful and excellent speaker. Actually, she's our mentor, she's our guide, she's our clinical and chemical pathologist. All over, she's the in charge of our core laboratory, Zayed Military Hospital, Abu Dhabi. So I sincerely, with all pleasure, happiness, gratitude, and love, I warmly welcome my ma'am, Dr. Mai Hamad. She is our motivator. Anytime you can go to her office and discuss your problems. She's always interested to discuss the subject. Every day we have clinical discussion in our laboratory. Every morning we have 30 to 45 minutes sessions. We are attending her sessions. So it will be a wonderful session for all of you. Thank you so much for attending this webinar. Once again, I welcome all of you to this session. And to talk about more about the speaker, I request my brother Arif. He is also our colleague in Zayed Military Hospital, and he will introduce you the speaker, the wonderful speaker for today, Dr. Muhammad. Thank you so much. Thank you all.
Thank you, Latifka. Sorry, thank you, Mr. Abdul Latif. Okay, respected ma'am and our esteemed speaker, Dr. Mai, our inspiring Dr. Chandran, patron of ALS, my beloved ALS directors, Mr. Abdul Latif and Mr. Shaji, and our colleagues at Zayed Military Hospital, Abu Dhabi, our teachers, dear ALS faculty and laboratory community members. Good morning, good afternoon, or good evening, depending on where you are joining us from. On behalf of Academy for Laboratory Science, I am extremely delighted to welcome you all to the very first session of our Quality Management Program webinar series, which comprises of a total of 3 sessions, pre-analytical, analytical, and post-analytical. As many of you already know, ALS is a platform built on a powerful vision to be a transformative force for clinical laboratory professionals. Our goal is to foster lifelong learning, promote professional excellence, and support career advancement. At the same time, we aim to build a vibrant, supportive community that connects talent with opportunities both locally and globally. Through initiatives like this webinar series, we are committed to helping laboratory professionals grow, share knowledge, and thrive in ever-evolving field of clinical laboratory medicine. Quality management in laboratories is not just a procedural or accreditation requirement. It is the backbone of trust, accuracy, and reliability in diagnostics. As John Ruskin wisely said, quality is never an accident. It is always the result of intelligent effort. This effort in our laboratories ensures that every result we produce inspires trust rather than doubt. In a world where patient care relies heavily on accurate diagnostics, clinical laboratories bear the immense responsibility of upholding integrity, accuracy, and precision. Today, we are extremely delighted to introduce Dr. Mai Farooq, a distinguished pathologist who exemplifies this unwavering commitment to quality. She is currently serving as a consultant, clinical and chemical pathologist, and in charge of core laboratory at Zayed Military Hospital, Abu Dhabi. It is the biggest tertiary hospital of UAE Army, about 400 beds, and the hospital is JCI accredited. She was involved in diagnosis of COVID-19 infection, follow-up of cases, and detection of immune response to COVID-19 vaccination. Dr. Mai did her MBBCH degree from Faculty of Medicine, Ain Shams University, which is a prominent public university located in Cairo, Egypt. It is one of the oldest universities in the country and holds a significant place in Egyptian higher education, ranking among the top universities in the region. Later, she got her master degree in clinical and chemical pathology from the same university in 2002. She did her residency in Ain Shams University Hospitals, which is one of the biggest medical schools and tertiary referral hospitals in Egypt. Later, she worked as a specialist in clinical and chemical pathology, Police Academy Hospital, which is the largest referral center for all the people serving in different police sectors in Egypt. Before joining Zayed Military Hospital, she was working as a specialist in clinical and chemical pathology, LLH Hospital, Abu Dhabi, which is a CAP accredited laboratory and a JCA accredited hospital. I have had the privilege of knowing Dr. Mai since I joined Zayed Military Hospital, and I always feel deeply honored to be part of her team. Her dedication, leadership, and passion for excellence have set a gold standard in our field. We are incredibly fortunate to have her share her insights with us today, and I'm confident her words will inspire us to prioritize quality in every aspect of our work and even our life. We are truly grateful to Dr. Mai for graciously accepting our invitation to deliver this webinar series. Despite her incredibly busy schedule, and her presence here is a testament for her passion towards advancing our profession. Her willingness to share her expertise with us is greatly appreciated, and we are honored to have her with us for this webinar series. Thank you, Dr. Mai, for making time to contribute to our learning and development. And audience from all over the world, we are excited to have you join us for this informative and engaging journey into the world of quality management in clinical laboratories. And I request you all to join using your name, as we will provide certificate of participation at the end of the 3 sessions based on your login details. So you have to log in using your login name. Okay, that login name will be used for giving you participation certificate. We encourage you to actively participate, ask questions in the chat box, and make the most of this opportunity to learn from our expert speaker and fellow distinguished attendees. Without much ado, I would like to invite Dr. Mai to take the platform and take us through this wonderful journey.
Thank you so much, Yarif. Thank you, Abdul Latif. I am the one who's honored for your invitation. I am honored to work with you. You are my sons, my family. Actually, not only you, all of you from Zayed Military Hospital, and from my first spot here in UAE is LLH Hospital. The senior staff are joining us here today. I am welcoming them also. I am honored to work with them and with you all. Without your great effort and your success in your work, we would not have reached this level of quality. I am here today to share our story all over the world, the quality in Zayed Military Hospital, and the quality was in LLH Hospital. So thank you so much. I am honored to be a speaker in this wonderful, excellent academy. Thank you so much. I'll now share the screen. So we will talk today about total quality management. Before we talk, I disclose this lecture. I have no financial disclosure or conflict of interest with the presented material in this presentation. Our learning objectives today: how to define quality, what is the total quality management, what is the quality assurance cycle, what is the element of quality assurance program, how we can monitor and control pre-analytical variables, and we have a lot of case discussions. So first of all, what is quality? What is the definition of quality? All of us talks about quality, but the quality, as simple as that, it is conformance or fulfillment of requirement and satisfaction of our customers. Customers mean our patient, of course. So fulfillment of this requirement as well as satisfaction, if we achieved quality. And if we talk about quality, we should understand what lies under quality, which is the quality cost. We have two costs, cost of conformance and cost of non-conformance or not fulfilling the requirement. Does the quality cost a lot? This is a question. Does it cost a lot? Yes, it does. It costs a lot. So what is the cost? Cost to prevention. Example, we are giving a lot of training, a lot of continuous medical education programs, calibration is there, maintenance there. Also, we have an appraisal cost. And we hire some companies to come and inspect. We have GCI inspection, CAB inspection, external quality control, daily internal quality control. So it is costly. We are producing a lot of effort and a lot of money to gain this quality. In the opposite side, what is the cost of non-conformance or non-fulfilling the requirement? We have an internal failure cost, like we have to do the rework, we have to repeat run, we have to repeat steps to assure that our work is okay. And we have an external failure cost also. Many complaints will come to the lab if we did not go through the quality assurance program. We will repeat the request, we will repeat the service, and most important is losing our reputation. So the cost of quality, understanding the quality and the cost lead to a new perspective, the relationship between these two concepts, quality and cost. So if we implemented the quality, the cost will be reduced. So it is expensive, yes, but the more expensive is to lose your reputation. So it is very important to understand that how much you do to perform a quality procedure, this is nothing. In one test, you lose your reputation upon. So this is very important. What is the total quality management? It is a philosophy as well as a management process for improving the quality of all aspects of the lab work. The framework of total quality management is quality lab process, which include analytical process, general policy and procedure that define how work is done. Quality control, it is statistical control procedure as well as a non-statistical control procedure like temperature monitoring, noise monitoring. Quality assessment, it is a broader measurement and monitoring of the lab performance like a turnaround time. Quality improvement, it is a problem solving to help to identify the root cause for any problem and help to solve it. And quality planning, provide planning steps for the quality management program. So we have these 5 pillars, these 5 components which work together in a feedback loop. So it is a dynamic process, not a step-by-step process. It is a dynamic process. Feedback loop illustrate how continuous quality assurance is accomplished and quality assurance is built up in our lab. Who owns the responsibility? Everyone owns the responsibility. Laboratory, clinician, as well as administration. We have the cycle inside the lab. It comes with 3 phases: pre-analytical, analytical, and post-analytical. Pre-analytical start with pre-analytical. Physician brain will take a clinical decision, test selection, and test request. Pre-analytical process involves sample collection, identification, sample transport, and sample preparation till we reach the sample analysis in the analytical phase, and the post-analytical will be in reporting, post-analytical in the interpretation of the result, which the physician will depend upon to take an action and will give an outcome. So the percent of errors in the lab testing, the scientists came to a conclusion that in the pre-analytical phase, from 65% to 75% of error are related to pre-analytical phase. So because of this, I made a certain lecture for the pre-analytical errors. And according to official data, from 60 to 70% of clinical decision about hospitalization, discharge, as are based upon lab result. So this showing us how much important our lab performance, any step in the whole cycle is very important for taking decision in hospitalization and discharge of the patient. What are the variables in the pre-analytical step? Appropriate test selection and utilization by the physician, patient preparation, patient identification, specimen identification, collection and transport, separation and aliquoting, lab logs and worksheets, transcription error, and finally, the turnaround time in the pre-analytical phase. We will talk about each and everything. Proper sample utilization, with an emphasis on the cost of medical care. The physician cannot ask for everything for each patient. This is wrong. This is a wrong behavior. There is a limitation of volume of stat request, and this is very important to us. When you misuse the priority of the request, this will affect other patient safety. For example, patient came to the ER with a stat label profile, and we have an automated system that prioritizes the stat order upon the routine request. The stat label profile run before a routine cardiac profile, which has a critical result for another patient. So you delayed a critical cardiac profile because you misused the stat priority of the lipid profile. Issuing guidelines for use of different lab tests. We should establish a diagnostic algorithm, like in case of thyroid disorder, chest pain, what we should do. And we should keep a careful monitoring of test requests and their appropriateness. This is very important. We had a case study in our lab that we carefully monitor the stat request. Is it correlating to the patient clinically? Is it allowable to ask for hemoglobin A1C, for example, as a stat priority? No, it's not allowed. So we took a corrective action, and we made a meeting with each and every head of department, and we showed them a small video that how the stat sample, whatever the request was, is taking the priority upon the routine tests. And after this, we kept on monitoring this process, and we initiated an incident report against the one who's not following our policy that mandate the taking care of the stat or any test priority. This is test utilization. How about patient preparation? Lab tests are affected by many variables like food intake, alcohol, drugs, smoking, rest, exercise. Instruction concerning patient preparation should be first included in our standard operating procedure and should be transmitted to the patient, both written and oral. And very important to be strict to the patient language that he understands. In many countries, we share different languages. So you should give him a written and oral instructions in a language that he can understand. In an outpatient specimen identification, in the outpatient, correct patient identification before sample collection is extremely important. Identification in our lab or in our hospital depends on two patient identifiers, like patient full name, not first name, not last name, patient full name, and the hospital medical record number. This is for the outpatient. For the inpatient, identification, every patient should have identification bracelet, which include first name, date of birth, and unique hospital medical record number. Proper identification should include three-way match. So how I identify a patient with a bracelet? First, ID, patient ID in the bracelet. Second, the request form and the patient stating his or her name. You should ask the patient, what's your full name? He will tell you, I am Ahmed, I am Muhammad. It's not accepted. He should tell his full name. In any step you deal with the patient, please ask the patient to state his or her full name. If the patient does not have an ID bracelet, ask the nurse responsible for the patient to identify the patient and to place the bracelet. طيب, how about unconscious, unidentified patients? This can happen? Yes, it can happen. In case of disasters, it can happen. In case of road traffic accidents, it can happen. Outside the hospital, there is a road traffic accident and coming 10 patients without any identification. So there must be a unique system to identify those patients. So in case of disaster, for example, in our hospital, we have an identification system. It is an adult or a child, male or female, and coming from which zone. These zones we need, in case of disaster, to segregate patient. Is it the patient is critical in the red zone in the emergency, or the patient is normal coming walking in the green zone in the medical outpatient, or he's in between this and this, so he's coming from the surgical yellow zone. So this is the sticker we put for the patient, and if the name is there, we put the name. So we identify each and every patient, and then when we initiate his correct name and his number, medical record number, we shift those data, manual data, to the electronic system. So this is very important to know and to be strict to these rules. We have a lot of cases. I am showing you an example how much patient identification or demographic data is very important for release of our safe lab result. For example, we have this patient with an alkaline phosphatase 200. It is within the normal range. Same patient with an alkaline phosphatase 200, but it is high. What is the difference between this, the first result, and the second result? The difference is the age. In the demographic data, for the first patient, it was wrongly written 3 years, and this male patient was 30 years. So see how much it affects the patient safety when we say that within 3 years, male patient 200 alkaline phosphatase is normal, but it is very high in 30 years old. So see how much it can affect the patient result. Another example, first patient with a total PSA 6, and it is high. Second patient, same 6, but it is normal. Why? Because the second or the first patient, he was 50 years old, and his reference range less than 3.5 nanogram per mil. But in above 75 years old, 6 is within the normal range. Another patient, this patient with a prolactin 28, which is high for his agent 6, and for the other patient, 28 is normal. Why? It is high in the first patient and normal in the second patient because of wrong 6 was entered in the first patient. She was a female with a prolactin level 28 nanogram per mil, and this is within the normal range for this age and 6. Another example, fasting insulin. For this patient, fasting insulin was 20 units per mil. Same result, fasting insulin was 40 units per mil. What is the difference here? Here, patient preparation. Patient preparation, first patient, he was really fasting. But the second, same patient, he was not fasting. So pre-analytical preparation of the patient made a lot of difference in this result. Another case, see, it is a fasting insulin. Another patient, blood glucose level. For this patient, it was 110 with no comment. And the other patient, same 110, but it is high for the agent 6. Why? Because in the first patient, we did not know the fasting state. So we released the result, but if fasting will be the range like this of random of 2 hours postprandial will be like this. In the second one, the order was fasting blood glucose. When this 110 comes in front fasting blood glucose, so it will be, of course, high. So you can decide it is high or normal. So proper order, if the physician ticked blood glucose, we don't know if the patient fasting or not fasting or postprandial or whatever. So if he choose the proper order, fasting blood glucose for this fasting patient, the result will be interpreted correctly. So after these cases, we will discuss the remaining of the pre-analytical variables, specimen identification. Many errors comes from handwritten labels and request form. These can be eliminated by careful comparison between patient name, date of birth, his ID number, and hospital medical record number. These data on the request form as well as specimen collection label. The use of barcode technology significantly reduces this identification problem. I am here explaining the routine manual request form and orders, but actually in our hospital, we use the barcode technology and the scanning for each barcode. Each specimen must be accompanied by a request form which have important details like patient's full name, age, gender, patient ID number, coming from the ward or from the outpatient, the type and source of specimen, date and time of a collection, the investigation required, any clinical note summarizing the patient illness, name, stamp, and requesting clinician ID must be there. Why it must be there? Because if there is a critical test result, we should inform and follow our critical value reporting policy. So a request without a clinician ID, name, and stamp cannot be accepted because we don't know from where this patient coming from, which outpatient department or inpatient, and who's the clinician in charge of this patient. Here, one of our old manual request form, as you can see, we should fulfill all this. See patient name, age, nationality, occupation, the requested test for the patient, and any other request, diagnosis, and if he's taking any therapy, any treatment, patient form, if we want to contact the patient again for recollection or for any reflex testing, ward or coming from where, collection time, date, and collected by whom, receiving time in the lab, and date and received by whom, and this should be totally fulfilled or fully fulfilled, and we should not accept any sample inside the lab without this full request form. Type. What is the causes of specimen collection errors? Prolonged application of tourniquet. As we all know that prolonged application makes anoxia, that leakage of some solutes from the cells like potassium. Potassium is high because the phlebotomist put the tourniquet for a longer time. It causes also heme concentration. If you have any sample with increased proteins and protein-bound constituent, please think about prolonged tourniquet. Also, intravenous infusion in any arm that we will collect the sample from it in the inpatient department. It can dilute some analytes and heme concentrates some analytes. If we are infusing potassium, for example, and the physician want to evaluate the potassium level, they cannot collect the sample from the same arm. This is daily routine, our problems with the ICU nurses, that please do not collect from the arm that there is IV, or stop the IV till you collect, before you collect the sample. Hemolysis. It's the analytes within the RBCs, like phosphorus, ALT, AST, LD, interference in some method like bilirubin of our phlebotomist to choose the proper diluent can decrease the calcium level. Type. How to avoid specimen collection errors? Assign a well-trained team in the phlebotomy department. Purchase high-quality collection tube. This is very important. Even if it is expensive, it is not as expensive as your reputation. Avoid pre-labeling of the collection tube to avoid error. This is very important, and it usually, this point exactly, usually make a conflict between I do prepare the tubes, label them, and then collect. No, please do not do this. Verify patient name and let the patient state his name, verify the patient identification, print your label, collect your tubes, and then label them. After again asking the patient for his name and verify that your labels, the correct labels for the correct tubes for the correct patient. Blood collection should be from peripheral vein whenever possible. Do not probe several times. Do not reposition the needle. Syringe transfer is discouraged, but if needed, do not use large volume syringe. Do not apply forceful transfer of blood. Blood sample should be adequate in quantity. Proper mixing with an anticoagulant. It is very important. The identification of the phlebotomist should be maintained. Phlebotomist should, if he's working manual technique, should sign the tube as well as the request mentioning the time of collection. Physicians to be encouraged to report inconsistent result. Actually, we are taking this as a positive step towards us, not a negative step. Any physician has a highlight or an incident or something, we encourage them. Why? Because this will elevate our quality performance. Almost always, our door is open to any incident report or any comment or any advice from clinician, because without them, we will not see the proper picture or the real picture of the lab performance. If we are performing and produce an extra effort and nobody sees this, or nobody appreciate this, or even have a comment on this, so we are flying in a different or sailing in a different ship. Any problem should be reviewed with the person in charge, and the quality performance should be the people who is maintaining a quality performance should be rewarded, and this is very important. You should support your staff by continuous medical education, by encouraging them. If they did a mistake, yes, it is a mistake, but repeat education, repeat training, elevate their level to reach the proper level to provide a high quality performance. We all know this, that there is the order of drawing, and our phlebotomist knows by heart this sequence. And how about the specimen transport? This is very important, and it can affect the specimen integrity. Stability of specimen during transport is critical. The effect of time, like in monitoring the glucose level, temperature, like blood gases, light exposure, like total bilirubin, may have the effect on the stability of the analyte. Some labs accept the change less than 10%. Others relate to medically significant changes or a percent of the established analytical variability. Dispatch the sample in a phlebotomy room to the lab as quickly as possible and keep the sample in a cool box until it's sent if there is a delay. Losing sample, missing test should be reduced to the minimum. So our dynamic quality process should every day monitor this step and evaluate your performance. And if there is a defect, please highlight it, correct it, and keep monitoring and evaluating the process as per each shift, each day. In our lab, we recently introduced Alinity IQ Indexer sample transport system. Actually, this is really affecting our performance. It automates and simplify phlebotomy, digitally document the sample data during transport, improve our visibility and processing. How it improve our visibility and processing?
Sorry, doctor, there is a sound we cannot hear properly. Can you please check the sound system? All of you, please wait 1 minute. She will clear that one. Thank you so much for your patience. Doctor, it is not audible. Thank you so much for your patience. Doctor is checking her internet connection. I can see Mr. Aslan, Barisha, Alberto, Percy, everyone there. Thank you so much for joining us. Mr. Percy is from South Africa, and Aslan is from Kosovo. We are part of Zaid Military Hospital Core Lab team. Thank you so much. Yes, doctor, it's okay now. Can you continue, please? Thank you. Shaji, can you please unmute, doctor? Yeah, it's okay.
It's okay now, yeah, Abdul Latif. Can you see my screen?
Very perfect now. Very perfect. Yeah.
Just 1 moment. We'll start from this.
Yes, doctor. Yes.
So from this slide, Abdul Latif?
Yes, 6. From here. Yeah, exactly.
So we recently introduced this sample transport system, which can collaborate a software that can automate, simplify phlebotomy, digitally document sample data during transport, and improve visibility and processing. So how this system works? Actually, at the phlebotomy site, it records, this is like a reader, barcode scanner, and a rack, automated rack. Record sample ID, phlebotomist, collection time. Shippable racks eliminate the need for individual bagging. And this is very important. This rack can visually identify wrong tube, insufficient tube, wrong tube for a wrong test. If there is a hemolysis, obvious clot in the test, it can recognize and it will refuse to transfer this sample. It will give you a visual alarm telling you that there is something wrong with the sample, hemolyze or whatever. And during transport, this is very important. It records the temperature, any turbulence during transport, and the transport time. It supports the compliance and allows quick identification of the out of tolerance or missing sample at receiving site. This is very important, and this is mandatory by CAP, that sample accessioning, sample condition must be recorded all over the transfer process. And this is very important. If there is any delay, any out of tolerance or missing sample at receiving site will be recognized. And in the lab, in the receiving area, specimen reception, record sample ID also, phlebotomist collection time, shippable racks, eliminate the need for individual bags, and for lab accessioning, stat test will be by itself identified, out of tolerance or missing samples are visually identified for easy access to improve the turnaround time, the pre-analytical turnaround time. So this really affected our performance. Does it really affect the performance in our lab? This is the answer. 0 samples were left behind since the implementation of sample transport system. We usually had this problem that when time comes to go home, some sample will be missed in the centrifuge. Or we have satellite labs that refer samples to us in the central lab. Sometimes the driver will go somewhere all over the day and he will be delayed. And the samples, the cold sample, will be room temperature. When it comes to us after this whole day, it will be either hemolyzed, glucose will be 0. We face this? Yes, we face this. And we will recall the patient for recollection. A lot of problems will be there. So from the time we implemented this software and sample transfer system, 0 samples had such an errors. So this is a very much improvement of our quality for the patient service and for the turnaround time. The 7th point is the specimen separation and aliquoting. Of course, this is the manual work. Our main variable, centrifuge performance, monitored by speed, time, and temperature check, and continuous maintenance, container monitoring, collection tube, stoppers, pipettes, and aliquot tubes are the source of calcium and trace material contamination. Cork and rubber stopper increase the calcium by 10 to 50%, up to 50%. Yani be careful. It is not 0.1%, it is from 10 to 50%. Some plastic material absorb some trace amount of some analytes like PTH. So specimen separation and aliquoting problems, we should overcome this by personal monitoring, and we should hire a trained and supervised employee. Written SOPs should be in place, because if I am a phlebotomist and there is a strange test, I don't know which tube to collect upon, I should refer to my SOP. It is not a shame to always refer to your SOP to have a guidance from your written document. Personal performance and safety should be maintained all the time. The throughput time, turnaround time are important part of performance, which can be calculated by recording time of specimen arrival and the time when the processing has been completed. The identification of technologists should be recorded to facilitate the detection and correction of any problem, or identify the good performance and highlight it and encourage your colleagues to maintain this high performance. Lab logs and work list. Once the specimen come and request arrive from the laboratory, check the matching of patient name, identification number on the request form and specimen collection tube. Check the adequacy of the volume, if there is any lipemia or hemolysis. Check the requested tests are suitable for the received sample or not. The request form must include comment with a specimen priority as it is stat or routine test. Compromised tubes will be rejected, and we have a sample rejection policy. We should follow this policy and document our rejection. Samples without relevant order should not be received in the lab. And this point all eliminated by lab information system. Then required the identification, information, arrival time, and request test in the master logbook. Avoid specimen mix-up and run sample through barcode to avoid the same through using lab information system. If assays are to be done immediately, record the specimen identification in the worksheet. If run is in control, proceed with the assay. The test results are transferred through LIS system to the result or report form. However, prior to reporting, the result should be checked by authorized medical personnel who will validate it. If the specimen for retest after dilution or any assay problems, this should be indicated in the master log or on the delayed report log. If the specimen is stored for subsequent analysis, it will not be assayed immediately. So it is identification, arrival time, and requested test should be recorded in the master log. Transcription error. It exists with a manual data entry. Computerized LIS system reduce this error through the use of check digits, limit check, test correlation checks and verification check with master hospital files. Actually, in our lab, we not only using LIS system, lab information system, also we use analyzer management system. We have a middleware that contribute with or correlate the sample request or the physician request with our performance cycle inside the lab. Maybe I will give one lecture how to use the middleware for maximum utilization of the data, patient data. Turnaround time. Increased turnaround time due to delayed or lost requisition, specimen, and reports. We should identify the cause of delay by monitoring the actual time of the specimen collection, receive in the lab, processing, analysis, and reporting. It can be done manually or by using computer or a middleware. In manual method, timestamps can be used, placed in the blood collection, specimen receiving, processing, and result reporting areas, as well as wards. This turnaround time monitoring can be as any quality control variable, and limits can be established to flag out-of-range specimen, and we should do a root cause analysis for increased turnaround time as a quality performance indicator, and we should keep monitoring this indicator. My opinion always that you should keep monitoring turnaround time in the pre-analytical, analytical, and post-analytical as continuous process. Do not stop. If for glucose, if your turnaround time is fine, shift to another analyte, which is your turnaround time is not fine, because you will keep improving yourself. It is a dynamic process. Keep improving yourself and highlight the defects or highlight the challenges you have in your lab. And by this, we will be reaching our end of this lecture. And I am sharing with you here a standard operating procedure my daughter made when she's in the 4th grade of planting seed. Step 1, we put a soil. We will put soil into a cup. Step 2, we put 7 seeds into the soil. Step 3, we water the seeds. Step 4, we put the cup in the sunlight on the window. So she wrote her own SOP, and I was so much proud of she's writing her steps. And I want to remind you that quality, it is invisible when it is good, and it is impossible to ignore when it is bad. Our take-home message, the very important message to take home, a reputation based on 10,000 good quality result is damaged by only one poor quality result. We should keep this in mind. Do not consider that all extra effort you are producing in your lab will go with the wind. No, you are protecting your reputation, the reputation of the institute you are working for. And we all had attachment to our institutions, and we want to keep a very good, excellent reputation of our work and our institution. Those are the references I used in my lecture. I'm so proud that I am using the first reference. Those are my professors that I am usually go through their books, and I use a lot of data from them. And by this, we will be reaching our last slide, and I will open for discussion.
Thank you so much, Doctor, for the wonderful session. We are open for the doubt clearing session for next 5 to 10 minutes.
Yes.
Anyone can raise the question, please. Yeah. And I would like to inform everyone that this is the first session. Actually, we have 3 sessions. This is the first session, pre-analytical. We have a wonderful and beautiful analytical and post-analytical sessions coming on, inshallah.
Inshallah.
So, inshallah, we will decide the date later. Yeah.
Also, ma'am mentioned this one, middleware also in between.
Yes, of course.
We are happy to hear, ma'am.
Yes, of course, يا عارف. This middleware will be in the analytical process.
Okay, you will include. Okay.
For a professor in the middleware يا عارف. You عبد اللطيف Aslan with us also.
Yes.
I don't know who's us with the Zaid military. Those are that I am proud to work with them. All of them, every one of them is a professor by himself. يعني I don't know if you can hear me.
Yes, ma'am. Yes, ma'am.
Yeah. So inshallah, in the analytical phase, we will discuss about how to use, how utilize artificial intelligence, how to use middleware, what is the benefit of the middleware in general, not a specific middleware, how to put an objectives and to choose your middleware upon. This is very important. All the era is going nowadays for the artificial intelligence. Maybe we'll have a lecture about what is the definition of the artificial intelligence, how we can utilize the artificial intelligence inside our labs to increase the safety, increase the quality, increase our performance. Sometimes when there is a hidden area we don't know about, we are afraid of. But when we uncover this area, we will actively participate in it. So my advice, please read about it and prepare yourself for this lecture, inshallah.
I am so happy that many teachers and students from various paramedical colleges from India have joined this session. Thank you so much. We will continue our journey, and Dr. Mai will be with us. I promise you, she has other wonderful lectures like the great imitator on syphilis, hepatitis serology. Many lectures are with her. Inshallah, we will continue. Doctor, we request you to be with us through our journey.
Inshallah, ya Abdul Latif, it's my pleasure and my honor to have my colleagues and my professors, my sons and daughters, and from Egypt, they are joining us. And I'm really honored to be a part of your organization.
So it is a global event now.
Yes, of course. It should be.
Yeah, okay.
Any comment
Any
or
questions?
question?
Any questions? You can ask questions on the chat box also. If
Yes,
you are
you
not
can.
able to talk, please raise your questions on chat box.
Or if you want to send to Abdul Latif, he will come to be in the lab and we will sit together and answer all if you want.
Yeah, sure. Thank you so much, Tom.
Thank you so much. Thank you. I really appreciate your efforts.
Thank you so much. So we are going to conclude this session. Actually, we will continue with again. I will remind you we have two more sessions on this topic: analytical and post-analytical. And certificates from Academy for Laboratory Science will be issued to everyone who is participating in the program, this global event. And I am so happy that even before 1 hour, I was talking with the doctor, and she was saying that I was behind this seminar, this session. I was preparing for the last 4 hours to include the latest thing. See her dedication and commitment. A big salute, doctor. Thank you so much for your commitment and presence here. And students, and this will be a fruitful session for all the students who are graduates and postgraduates from various paramedical and medical colleges across India and other regions of the world. Thank you so much. Thank you so much, doctor.
There is a question in the comment box. Doctor mentioned about don't use large volume syringe. Will it be like what is the will it be up to what volume? That is the question. Up to what volume syringe we can use in the
Actually, they use the 5 milli syringe. If you are forced to use it, you don't have the vacutainer, and you are forced to use this, you should use it under low pressure when you transfer your blood or serum or whatever in force it. Don't push it because it will rupture the RBCs. So better not to use it, but if you are forced to use it, not more than 5 milli, better to be less, 3 milli, but be careful not to rupture the RBCs. Do not make it forceful in the tube, please, because it will affect the patient results. Now the vacutainer is very cheap. So we can use this vacutainer system better than using a syringe. I do not encourage at all using the syringe now.
Yeah, but in India, most of the people are still using vacutainer, not vacutainer, syringes.
I understand and appreciate if you are forced to use it without pressure.
Okay, and they're asking any recommended size for a needle gauge size.
For
Needle gauge size of the gauge.
Wallahi, I don't have any recommended size, but we can search online. يعني it is according to the patient type, according to many variables. But you can search online, you will find the appropriate for your test, for your lab, for your patient. You can find the recommended ones.
So these are the question came in the comment box.
طيب الحمد لله.
Shaji, one more question is there.
Yeah.
What about lipemic sample?
Lipemic sample?
Lipemic sample.
Lipemic sample, yes, ya Abdul Latif?
Yeah, sir.
Yeah, that is the question about lipemic sample. Yeah.
Actually, this is a challenge. Lipemic sample, what we do? First of all, we will make sure that the patient is fasting from 12 to 14 hours. If you need this patient, but some patient after fasting from 12 to 14 hours, it will be milky serum, even if he's fasting. And this is a real challenge. According to the manufacturer, some manufacturer or some providers for the service telling that you can put recentrifuge, ultracentrifuge the serum. Some analyte or some test does not interfere, but a lot of tests, milky serum can interfere with the analysis. But what you can do, you are alone, 3 a.m., and this is a lipemic sample coming from ER. What to do in this case? My recommendation, recentrifuge the sample and inform the physician, the ordering physician, that some assays will be reported, but we are not confident with the result because there is interference with the lipemic sample. You cannot do anything. Some manufacturers recommend put like ether, like whatever, but I don't recommend this. If you cannot report, just inform the physician, and most important, document this message. If you did not document, you did not inform. Even if you inform it, oral information, please document it on the system that the sample is highly lipemic and there is a possible interference with the results.
Doctor, someone asking about
Thank you
the
so much.
pre-dilutions, like dilutions. It's coming under pre-analytical, right?
Pre-dilution for lipemic sample?
No. All the samples, like high value samples.
High volume sample?
High value. Suppose it's critical value, some other like.
This is a very important question. So, high concentration of any analyte. Hello?
Shaji, please.
Shaji,
Shaji, please mute.
1 minute.
1 second, doctor. 1 second.
Okay. Muted now. Yeah.
Yeah, doctor,
Yes.
please continue.
Yes. If you want to do dilution, there is something called dilution protocol. Actually, this is mandated by CAP or any accreditation body. If you have an analyte and the insert written to you that the AMR analysis management range is from, for example, for 1 to 10 milligram per deciliter, more than 10, dilute. So you should dilute, but according to, or when you can stop dilution, this is according to the manufacturer recommendation. If the manufacturer said 1 in 2, 1 in 5, خلاص, your limit is 1 in 5. And it should be written in your SOP, standard operating procedure, and the diluent is written there, and the dilution is written there. And how about if you diluted and it's still more than? So you will report more than. And as per CAP, you cannot put the sign of more than. You should write more than, M-O-R-E, than. Because it is as per CAP. It should be obviously understood. So you should follow the manufacturer dilution protocol, and everybody should follow this. Not I am May today in the early morning shift, I will dilute 1 in 5, and Abdul Latif, next shift will dilute 1 in 10. No, it cannot be for the same analyzed same patient. No, it cannot be. First thing to do to standardize your procedure. Dilution protocol should be followed by May and Abdul Latif. All same. So this is very important, and it should be followed strictly.
Doctor, there is a question. Mentioned smoking affects the test result. Is it affects insulin resistance test, whether the smoking will affect?
Wallahi, there is some studies, yeah, Adil, telling that it affects. You know, every now and then there is a study coming up with a new information. Some studies telling that it affects the result, and some studies are telling no. So it is like it's not solid. But if the manufacturer recommended that the patient should stop smoking before the extraction of blood by a certain time, we should follow this. Follow the recommendation of the supplier or the manufacturer.
Thank you, doctor. Let us wind up the session. It is already more than 1 hour. Thank you so much. And on behalf of ALS and all the participants all over the world, from all over the world, we express our sincere gratitude and thanks to you. And we will continue, inshallah. And on behalf of ALS, I express all my sincere gratitude and thanks to all the participants. We will continue our journey. Thank you. Thank you so much.
So much. Thank you. I really appreciate. Thank you.
Thank you so much, doctor. So, good night. Good night, everyone. Ma salama.
Salam.
Going to wind up the meeting now. Thank you, everyone.
No one is ready to leave. I don't know why. Okay.
مع
Thank you,
السلامة.
doctor. Thank you so much.
Okay.
Ma salam.
Allah.
To leave?